Dr. Adil Khan is one of the national experts on robotic surgery, not only in kidney transplant, but he also performed the first liver transplant through robotic technique. He has trainees visiting surgeons from outside to learn about the robotic surgery. So we're very pleased to have him today to talk about robotic surgery and kidney transplantation.
Good morning, everyone. Thank you for the warm welcome and the invitation to talk about something that I do feel very passionate about, and that is robotic surgery, especially robotics in transplant. So just state I'm a consultant and a proctor for Intuitive Surgical, which is the main robotic company right now. So just to give a little bit of an overview about robotic surgery. So I'm sure you've all heard about it because it's something that I think at every hospital we hear more and more. So what it means is that there is a console in which the surgeon sits. They have little joysticks in their hands through which they control the instruments. Then you have a robot, which is that thing in the center of the platform, which has 4 arms. It's like laparoscopic instruments, but a little bit better. And then you require a bedside assistant for instrument changes, and you position it, and through that, you control the robot. I'm sorry, I keep on hitting the mouse. So contrary to what you'd think, the robot itself does nothing. It's all controlled by the surgeons. But it's something that seems to be the replacement for laparoscopy and the future of how we are going to do a lot of things. The view that you get is extremely good. It's 3-dimensional, and the colors are really vivid. There's no issues with the quality of the imaging. It's better than you even see with open surgery. And the instruments also are wristed, which means that they mimic the motions of the hand. So you get a lot of the same range of motion that you do while you're doing open surgery, as opposed to laparoscopy, which are very rigid and they're not wristed or angulated. So I think there's no doubt that robotic surgery is on the rise in the U.S. There are over 5,000 systems in the country, and it seems like every day there's a new hospital getting a new system. So that's something that we're going to see more and more of. The global trends of robotic surgery have continued to increases by about 30% a year, and most of that increase is in general surgery, and transplant falls in that category as well. So transplant is a little bit of a latecomer to robotic surgery, and the reason of that is, we have always considered ourselves to be MIS surgeons, but it's maximally invasive, not minimally invasive. We've always prided ourselves on making bigger and bigger incisions, but now, things are changing. I think it's part of the younger generation and the push towards doing things through smaller and smaller incisions and having patient experience be given a priority. So why robotics for transplant? So I think that, one, it definitely pushes beyond the limits of laparoscopy. You can do things that you can never do on the laparoscope. It's extremely well suited for transplant because the style of operating is very similar. The visualization and the instrument control is really, really good. It provides a lot of opportunities for innovation and going beyond where we were able to do before. Also now, as general surgery residents are getting exposed to the robot when they come for training, they want to get exposed to it and they want to use it during their fellowship. Also, very important, it prolongs the life of surgeons. You don't have to stand for hours by the patient's bedside in awkward positions. Now you can sit on a comfortable chair and operate, and it definitely makes you a lot less tired at the end of the day. We have to be fresh for the night because we get more phone calls, twice as many as Dr. Hughes showed. And of course, the most important factor, increasing amount of studies have shown that the outcomes with robotics are very good, and they continue to get better beyond what laparoscopy could achieve. So with that said, we'll talk a little bit about our program, how we went from a maximally invasive program to a program that's increasingly minimally invasive. We are a very new program, like most robotic transplant programs. We did 0 cases before 2018, and now we are the largest robotic transplant program in the US and probably in the world, but I don't know that for sure. We have built the program on the same principles that we have built our other surgical programs on clinical excellence, education, and research. So this is just a breakdown of our robotic volume on the transplant service. So again, before 2018, almost nothing. And since then, we've sort of increased at a 30 to 40% rate every year. And this year, we're expected to close around 220 cases a year, which is a pretty good number, and it's something that continues to go up. So all that means is that now we're doing more and more things minimally invasively, which means there are lesser and lesser surgeons walking around with the bigger traditional incisions. Lesser patients, not surgeons. So we have a 30% growth in case volume per year. So we have gone up from 2 to 7 surgeons. We have trained bedside first assists, which really helps with the case. We do both HPV and transplant. So this is about 50% transplant volume, 50% HPV volume. Outcomes have been excellent. And most importantly, we've sort of set up the system so it's safe, standardized, and reproducible, because we do believe in sharing this with others and helping others get to the same spot, because we do believe that this is the future of transplant surgery as we know it. So just some of the landmarks. So we started doing robotic living donor nephrectomies in 2020. Now we do all of our donors robotically. The next year, in 2021, we did our first robotic kidney transplant. Since then, we've done about, I think, close to 50. Earlier this year, we did we just used what we had learned from kidney transplants and did our first robotic liver transplant, which was also the first one in the U.S. That just brought us a lot more confidence in what we could do, and also helped guide us for the future direction. Of course, it takes a team, and we have been able to develop a really, really good team, because these things are not possible without not just the OR team, but also the hepatology and the nephrology teams. We all work very cohesively. As you've seen, there are 2 surgeons giving talks in this transplant nephrology symposium. So the other thing that we are doing is that we are a surgical epicenter in transplant robotics, which means we are an area. We are a center that other people can come and watch us and learn. And over the last several years, we have helped several programs develop robotic programs of their own. And these are just some of the names that you might recognize. And there's been a tremendous amount of interest. And this is something that we're definitely going to see more and more of. So what about kidney transplant, right? That's why we're here today. So in kidney transplant, you can do living donor nephrectomies, you do kidney transplants, and then there are other surgical procedures too, like transplant nephrectomies or revision of ureter strictures, and the robotic approach can be applied to all of them. If you look at living donor nephrectomy, we know that laparoscopic donor nephrectomy has been the gold standard. It's tried and tested. It's safe. We know that it offers very low rates of complications, and the patient outcomes are generally good, right? So what does robotics has to offer? It's also a minimally invasive surgery. Does it do anything better? Most people thought no, including us. We thought that, we're going to start off with it just so that we can build a team. Our end goal was to do kidney transplants. But once we started doing it, we felt that this was a lot better. It felt safer, it allowed better visualization, and the patients seemed to be doing better too, which didn't really make sense. So we looked at our data, and what we saw was, and we published this earlier this year, so we looked at our first 75 donor nephrectomies, compared them with our last laparoscopic donor nephrectomies. And what we saw was that the outcomes were, in terms of complications and all, were pretty low in both groups, as you'd expect. But the important thing was that the robotic donor nephrectomy patients seemed to be staying in the hospital significantly lesser time than the laparoscopic ones. And the number of donors discharged on day 1 was a lot higher after robotic than laparoscopic. And this didn't really make sense. There had been some data showing that maybe there was less pain with robotic surgery compared to laparoscopy. So we looked at that, and Kristen helped us with that, and we are actually just presenting that in a couple of weeks. So we looked at 150 of our donor nephrectomies robotic versus 150 lap. And we looked at their opioid use. So morphine milligram equivalents is what we converted all opioids to. And what we showed, again, that the length of stay was significantly less in this group, in this study as well. And the number of donors that were discharged on day one was also significantly higher in the robotic group than the laparoscopic group. And specifically looking at looking at the opioid requirements, the opioid requirements was significantly less in the robotic group. It was almost half on compared to laparoscopic group on day one. So we think that there really is something to that, and that's one of the reasons why the patients are going home early. So even among minimally invasive approaches, robotic seems to be better than laparoscopic. So what about kidney transplant, right? So this one's easy, right? Kidney transplant, traditional, has got a big incision. The bigger the patient, the bigger the incision, and now we are getting bigger and bigger patients, especially in the area where we are. You cut the abdominal muscle, so there's considerable morbidity from that. The wound infections and breakdowns can be really difficult to manage. They can take a long time, and then you have to cut down the immune suppression. Then you're struggling with rejection. You also get hernias, which are extremely challenging in this area. And then, of course, post-operative perinephric hematomas, about 10 to 15% of the patients need to go back for a washout during the initial hospital stay, which is a pretty high number. And then a lot of them go home with drains and lymphoceles, which stay in for a long time. So theoretically, robotics can really help with all of that. The incision, like I said, is bigger, and you have bigger patients, and we seem to be having bigger and bigger. I think our cutoff is supposed to be 40, but I think our average weight is 40 BMI. With the robotic approach, as you can see, the incision's a lot smaller. So you still need to make one bigger incision. We make it periumbilically. That heals better. You don't have to cut any muscles. And that's just to put the kidney in. And then you have additional trocar incisions on the side. So as you can expect, that patients generally have a lot quicker, faster recovery. The visualization is really good. You can see the great view of the external iliac vessels. Here's the vein and the artery on the other side. When you're sewing, the view is phenomenal. You can see every single stitch, every single detail a lot better than you can see open. You can see the vein here on this side, artery there on the other, and this is what the kidney looks perfused. There's the kidney, looks nice and pink. There's the artery in the front and the vein in the back, and I mean, a lot of us now prefer it to the open kidney transplant. We're also really pushing the limits. This is on the right side of the screen. This is a case that we did, a month ago. So there are 3 renal arteries. So you can see like 1, 2, and 3 in a single renal vein, and we did all of that robotically, and the patient did just fine. So it really does seem to be coming up more and more, and we believe that soon it's going to be the new standard of care for kidney transplant, at least for the obese patients. These pictures are of 2 separate patients done within a week of each other. I did both of them. Both of them had a BMI of 40. This one was done open. You can see a big incision, had a wound dehiscence on day 2, brought them back, had to repair the whole fascia with a big piece of mesh. And this is the same body habitus patient, BMI 40, had a robotic kidney transplant, and then you can expect, which one did better afterwards. So it definitely does play a big role. So other robotic indications, transplant nephrectomy, ureter revisions, all of those are fairly morbid procedures open, but now we can do more and more of them robotically, and they go home the next day or sometimes the same day even. And of course, retransplants, multivisceral transplants, you can do the same incisions. You don't have to cut them on the other side. So a lot of that definitely adds to the decreasing the overall morbidity. So in conclusion, the future of transplant seems to be increasingly robotic. I think the future of kidney transplant is definitely robotic. Our prediction is that robotic approach is going to be the standard of care for living kidney donors and for majority of the kidney recipients, definitely the obese patients, which is where we're headed. That's all I had. Thank you.
Are patient with vascular disease still not a candidate for robotic?
Yeah, that's a great question. So, currently we have 2 contraindications, right? So, one is very small patients, so BMI less than 20, because it doesn't really make sense. In fact, you don't have space. It becomes harder to do it robotically. And the second are those with heavy calcification of the iliac. So as part of our protocol, everybody gets a non-contrast CT scan pre-transplant, and we kind of look at that. If they have heavy calcification of the external iliac, then it's not worth it.
Great talk.
Thank you.
What's the time between, like, for the robotic versus for of course, like open, just
Yeah.
3.5 hours? How about the time?
Yeah. So for the robot, it takes a little bit longer. So it takes we can do it in faster one in 2 hours, slower one in 3 hours. It takes a little less open. I think as we do more and more, we definitely get more and more facile. And my goal is always to do it in the same amount of time as an open. I think the critical time, the warm ischemia time, even though it's come down significantly from about 45 minutes when we started off to now we consistently do them around 30-35 minutes. It's still more than what it would be for open, but it really hasn't been any difference. I didn't show our data, but among the 30 that we've done, our DGF rate is less than 10%. If you haven't lost a single kidney, and I think only one patient had a hematoma. That too was an overcall in our earlier experience, and it washed it out. But otherwise, no drains on discharge. They don't get any wound hematomas, no wound complications, no wound infections, no breakdowns, and the quality of life is a lot better. So I think that as we do more and more and we get even better, I think it's going to be a game changer.
So, excellent talk. I just want to ask about resource use, and one thing we struggle with at our program is having sufficient access to robot time for our surgeons. So how did you build it up, or do you have just a lot of block time for training?
No, we did put in a lot of effort into that. I think as we start doing more and more, then you can ask for more and more. So every 6 months or so, we have a meeting, we ask for more time. And usually we get it because we can use it. We do a fair bit of cases. And depending on the programs, but most of these robots are leased. So at the end of the day, the programs want to have the robots used, right? Because otherwise they're paying the same amount of rent on it and it's sitting around. So it all depends on how you ask for the time. We have been very fortunate because our operative leadership and hospital leadership are all vested in building robotic programs. So it hasn't really been an issue for us. Yes.
Infocele complication also.
So nothing. So these kidneys are placed so we do it intraperitoneally, but we make peritoneal flaps, and at the end of the case, we retroperitonealize it by closing the peritoneum on it, and that does two things. One, it fixates it so that if they need a biopsy, you don't have to worry about it not being stuck to the abdominal wall. And two, we leave a little bit of a window right where the vessels are. So if there is any fluid collection, it just comes out. So I still leave a drain in for, I don't know why, but usually that drain comes out on day 2 or day 3.
Yeah, last question, Dr. Watson.
Can you speak to the uptake in terms of the training and surgeon buy-in? Because as you described, it's going to be something that's for developing the future, and perhaps a surgical program has a half a dozen surgeons or more, some who feel comfortable, some who don't. Can you speak to the retraining and the buy-in and the trajectory of growth?
Yeah, no, that's a great question. Like I said, transplant surgeons have been maximally invasive surgeons. They don't do anything minimally invasively. Even, the laparoscopic donor nephrectomies we do, 80% of them in the country are done with a hand port, which is basically cheating, right? So they're not very comfortable. But now the generation is changing, right? The old school generation is sort of slowly fading away and retiring. And now the younger, it is reality, right? In 10 years, I'll be in the part of that generation too. And the younger generation that's coming in, they are all experienced on the robot. Like, we had a fellow just start, and he did over 200 robotic cases during his residency. So when they're starting off, they're already way ahead of the learning curve. It took me 3 years to get to 200. They're already starting off with that much. So it's and they are the ones who are really pushing it. They want to do more and more on the robot. And I think that we're going to see that more and more. And right now programs are feeling the pressure. Everybody wants to build a robotic program. So they are sort of, we have visitors every month. And they're all struggling because, every program has their limitations and they have to relearn. And after 7 years of residency, 2 years of transplant fellowship training, if you tell somebody you got to go back and learn something from scratch, I mean, it's not the most comfortable things.
Okay, thank you.
Yeah.
Just one. Can we make it after?
Just technical point of view, you mentioned you need an assistant when you're doing the robotic surgery. That assistant person has to be a surgeon or could be a resident or fellow?
No. So it's it can be anyone. It can be a resident or a fellow or a surgeon, but we don't use any of those. We have trained PAs and OR scrubs in robotics. So we have a dedicated bedside nursing first assist who assists. We intentionally moved away from having the fellows be that person because they need to be on the other console operating. So we have 2 consoles, one for the surgeon, one for the fellow, and while we have a nurse or a PA on the bedside doing all the instrument exchanges. We prefer it that way too because we don't have to reinvent the wheel with every new cycle of residents, and the fellows definitely prefer it because they actually get to do things.
Wonderful. Thank you.
Yeah, thank you.
That was great. Thank you so much.